We would like to take another moment to thank our sponsors, whose financial support helps make CapTimes Idea Fest the important event that it is. Special thanks to our presenting sponsor, UBS, the Burrish Group. They have been a major sponsor since the very first Idea Fest. Major sponsors include HealthX Ventures, Exact Sciences, and Quartz. Co-sponsors are Madison Gas and Electric, Godfrey and Kahn Law, the University of Wisconsin-Madison, and Epic. Our Friends of Idea Fest sponsors are Wisconsin Alumni Research Foundation, Madison Community Foundation, University Research Park, Cargo Coffee, Doc Smokehouse, and Forward Theater Company. Our media partners are the Wisconsin State Journal, Madison.com, WKOW Channel 27, and Hinckley Productions. Again, we thank you for your support and for making Idea Fest 2021 a huge success.
And welcome to CapTimes Idea Fest. Really glad to have you here, and I hope you're looking forward to a day's worth of excellent talks, including this one about healthcare as a fundamental human right. I'm going to turn this over to our moderator, Christina Ott, in just a bit, but I'd like to take a moment to thank Quartz Health Solutions, which is one of our major sponsors and which put together this excellent panel together for the festival. Please give them a round of applause. My thanks to all of you for being here. We really appreciate it. If you're looking for further ways to support the CapTimes, I hope you'll consider becoming a member. You can find information about that at membership.captimes.com. One bit of housekeeping before we get started, and you're welcome to submit questions to the panel during the talk, but we ask that you use note cards that our volunteers have, and they'll take those up to Christina to work in as time permits. So without further delay, I'm going to turn it over to Christina, who is Vice President for Product Innovation at Quartz. She has more than 25 years of experience in the successful development of healthcare products and services, including experience on both the healthcare and deliveries and the health insurance side. Please give her a warm welcome.
Thank you, Chris, and good morning. Welcome, everyone, to Capital Times Idea Fest 2021. The topic, Reckoning with Change, and thank you all for spending some time with us this morning. I'm so happy to be here to meet and talk with all of you. And as Chris already introduced me, I'm Christina Ott, Vice President of Product Innovation at Quartz. Today, we're going to have a conversation. You're going to hear from a fantastic panel of healthcare leaders and community leaders discussing healthcare as a fundamental human right. We do know that racial inequities exist in healthcare today. This contributes to access issues and poor outcomes for historically marginalized communities. In the next hour, we want to talk. We want to have a discussion as leaders in healthcare to talk about how we can work better together and think differently to find ways to improve access and equality in healthcare for those that need it the most. As a leader in product innovation at Quartz, we're continually looking to find affordable healthcare solutions for all our customers. We constantly evaluate how to create products and distribution models to ensure that all communities get the coverage they need and they can access care. So let's get started. It is my pleasure this morning to introduce our group of panelists. Let's start with Carla. Carla Gaines has been working for over 27 years, advocating, developing programs that support the health and well-being of local families. These programs help to remove barriers to healthcare. Carla serves as the Community Liaison Manager at Quartz, supporting nearly 46,000 Quartz Badger Care Plus members. And it's my great privilege that I get to work with Carla on my team. Carla also serves on the board of directors for the Foundation of Black Women Wellness, One City Early Learning Center, and is the board president of Rainbow Project. She's received numerous awards for her work over the years, but most recently, she was awarded the Mike McKinney Award from the United Way of Dane County. Next, we have Dr. Ken Loving. Dr. Loving is the Chief Executive Officer at Access Community Health Centers. He's been practicing in family practice at Access since 1996. As CEO, Dr. Loving develops and implements Access strategic goals to support their mission of improving access to high-quality healthcare services and addressing disparities in healthcare treatment. Also with us today is Brenda Gonzalez. Brenda currently serves as the Director of Community Relations at the University of Wisconsin-Madison. Here, she serves as the liaison between the university and local community and nonprofit organizations. Brenda has extensive experience advancing corporate diversity, equity, and inclusion activities and initiatives, and has also worked in several healthcare administration roles that involved interpreter services, community outreach, and managing health equity initiatives. She has served on area board of directors, including the United Way and Centro Hispano, and she is the past president on the board of directors of Access Community Health Centers. And finally, but not least, I'd like to introduce Dr. Beth Zeidler-Strader. Dr. Zeidler-Strader is the Chief Behavioral Health Officer at Access Community Health Centers and a seasoned clinical health psychologist and behavioral health consultant. She serves as a senior leader at Access Community Health Centers with the mission of improving access to the health and lives of people who otherwise face financial, cultural, or language obstacles. That does prevent access to high quality and affordable care. Chris mentioned earlier, but I'll just note that there are going to be note cards passed out for questions. Please write down any questions that you have, and we will save some time at the end to ask the panelists your questions. We're hoping to leave about 15 minutes to do so. And as part of our format this morning, I will ask a question, and we'll start with one of the panelists, but I will ask each of them to respond to give their perspective on the question. So let's get started. Dr. Loving, let's start with you. It's important to recognize that societal institutions' racial inequality has led to disparities in medical care. A recent example at the national level was inequitable access to COVID-19 vaccines. What are some of the tangible action steps that we can take as a healthcare system to promote equity and access to healthcare services?
That's a great question. And before I get started, I just want to recognize my fellow panel members here. I've known Brenda and Carla since I moved to Madison almost, over 20 years ago. Yeah. And we worked together at the Harambe Village Center on the south side of Madison for many years. And Beth has been part of our team for a number of years now and serves as our Chief Behavioral Health Officer. So it's great to be here with all of you, but also with friends up here on the panel. So, I think to your question, Christina, I think there are a couple ways to look at this. I think the first I would mention is just sort of the local approach. And how do we do this locally? And I think we do it fairly well in Dane County because what really needs to happen on the local level is the health systems and people who provide health care need to work together. And of course, there's competition in our system, but there are times when you can set that competition aside and really work for the greater good of the community. The first thing you have to do is define what's needed in the community. And one of the best tools that we have that I think most people probably don't know about is the Dane County Health Needs Assessment. And this is something that's required to be produced. The Affordable Care Act requires it. And typically what happens is health systems will kind of put this together on their own and then try to set some goals around that. One of the things that we do here in Dane County is that is a common document. So it's worked on together by the health systems. And that then sort of puts out the particular things that are most concerning about our community in terms of health needs, and then there's a better chance that we can work together on those things. The way that we've done that in Dane County is we have something called the Dane County Health Council. And that was an organization that was created about 20 years ago, initially created by the county executive, Kathleen Falk. And part of what we were charged to do at that time was to do something about the growing number of uninsured people in our community. And so the Health Council was made up initially of lots of different groups. Over the past few years, it's been winnowed down a little bit to include the health systems, the United Way of Dane County, the Madison Metropolitan School District, Public Health. We recently added the Black Women and Children's Health Alliance to that group. And what we have been working on for the last 3 years is one of the things that is called out in that Dane County Health Needs Assessment, and that is the percentage and the disparity between low birth weight babies that are born and the infant mortality rate in our community. So we were very clear when we sort of reimagined the Health Council that we wanted to work on this particular issue, because this is something that is, it's really present across the country. It's present in our state and in our county. And in fact, Wisconsin has some of the worst infant mortality rate disparities in the country. And that's been true for many years. One of the things that happened in our community in Dane County was in the 1990s that African American infant mortality rate started to decline. And over those 10 years, it declined significantly, so that from 2002 to 2005 in our community, the rate approximated the white rate. And so what I'm saying is that disparity went away for several years here. Why that happened, we don't know exactly, but what it helps me be optimistic about is that we can ultimately do something about this intractable problem that we've been sort of living with for so many years. And so, that's one of the things that the Dane County Health Council has focused on to really, put our attention to, shine the spotlight on. But I'm encouraged as well in the way that we're doing this. This is not an approach where the health systems or anybody in the healthcare field is going to the community and saying, hey, look, we just created this great program. You should take advantage of it. Instead, what we've done is we've hired some consultants that work closely with the community, that get their opinion about what we should be doing. And then we are reacting to that opinion and trying to create with the community the solutions that are required to get back to that period in the early 2000s where we actually did something about this. And so, when you look at health disparities, and the infant mortality rate is just one of those, you can look at that needs assessment and you see these disparities all across the board. And this is something that those of us in healthcare have recognized for many years. And, this is our chance to start to work on one of the most difficult ones and then spread that work to these other conditions that we see. I mean, I'm talking about heart disease, stroke, diabetes care, length of life, these things that have just become part of what our community is, and we want to change that going into the future. So back to that idea about how do we make a difference locally, it really comes down to that idea about working together on this.
I'd like to add to that piece around thinking about how we work together. A big chunk of this is also thinking about mental health as help, right? And for a long time we had siloed care, and mental health was over here, or substance use disorder concerns, and physical health was over on this other kind of silo. And one of the things I'm really proud about that we're doing at Access is really whole person health and bringing together integration in primary care as a routine part of care. So Access was an early adopter. I've been at Access for 13 years. We've been 16 years of doing integrated care, which is really putting behavioral health providers, psychologists, social workers, on the medical care teams in the space that patients and individuals find familiar and acceptable already, to reduce the stigma that's attached with mental health services and to be able to access those services in real time. I think about the pandemic as being a really significant catalyst where people were able to say mental health impacts all of us. We've all had to navigate an immense amount of change and disruption to our daily lives and trauma and loss, right, associated with the pandemic. And we also know that communities of color have been disproportionately impacted by the pandemic, both from a fiscal standpoint, but also from a health standpoint. And so what are we doing to intentionally create supports and services to walk alongside and have ease of access to care? So when I think, what can health systems do? We can meet people where they are. And when you come into primary care, we see 70% of issues that come in have some kind of psychosocial component, right? And so having the ability to walk into an exam room in real time and see someone and develop a plan in partnership to say, how do we move care forward, is life-changing. And it's an important piece because it also destigmatizes and demystifies, right, what it's like to talk to a psychologist or a behavioral health provider. And Dr. Loving is one of our primary referrers, and I'm able to build on that relational currency that he has by trusting in another care team member to build that trust within the community and with the patients that we serve. And so when I think, what can health systems do? Integrated care is a huge portion of that. And Access has been a leader in providing integrated care, and we actually have several of our past trainees that have gone on to other health systems here in Dane County, both at Group Health and at UW, and really talking about how do we make a routine part of healthcare services, including mental health and behavioral health services, and then also ensuring parity, which we'll talk a little bit more about with future questions.
Sounds great.
Yes, my thoughts, I want to thank both of you all, because it gets my thoughts all kind of wrapped up together too, is that one thing when Dr. Loving talked about the Health Council, this year they just added health insurance companies. So our new CEO, Dr. Selna, appointed myself to the council, and it's been an amazing interaction because I've been, as you said, Dr. Loving, around for 25 years. I was there when the Health Council was formed, and Dane County is so unique. You all talked about this. Access, again, I was on the board when it first, at the Red House on Williamson Street. And so we are so unique. And when you talked about getting information from the community, that's how we build partnerships, and that's how health systems build partnerships, because we're not saying what you should work on or what you should do, but let's hear what you need, what's going on in your communities. And that was a huge part of us working on the Black maternal and child health. And so that has been an exciting project. It has taken years and years and years for it to get to where it is, and so it's going to take us time to move that dial again. But again, Brenda and Dr. Love and I worked at Harambe, where when those numbers did drop. And then we can anecdotally say that it was because of that partnership that we had, that one-stop shop that we had at Harambe, where we had clinic, we had access, we had dental, we had early learning childhood, we had Head Start, we had the library, we had all these entities at a one-stop shop. And so that's an anecdotal story that we are holding on to, that we're thinking of one of the reasons that it did go down, because we had a support. We had a support there. And so when I think about courts and what we've been doing, so for 27 years, I've had the great honor to work for courts and had the amazing honor to create programs that now they call social determinants of health. I tell everyone, I wish I would have coined that term 20 years ago. But when I developed the outreach program for courts, I knew Dr. Hansen at that time wanted a different medical model for an insurance company that just was in the form of creation. And he wanted an avenue for someone to go out in the community to go into the patient's home. What is really going on? When a provider says, they're no-showing, but why are they no-showing? It's because they're dealing with eviction. It's because they're dealing with other issues of transportation. All of these different things affect really healthcare. And actually, all those things are even more than the issues of healthcare, housing, education, transportation, even affect more than the healthcare piece. And so I think that, again, as we collaborate and coordinate services and systems together, it's going to make a difference, continue to make a difference in Dane County. Dane County is very unique. As Dr. Loving said, some 25 years ago, we had the health check clinics where we were addressing the needs of the uninsured, addressing the needs of HMOs that needed to get Medicaid members in for physicals and exams and just they couldn't get to the clinic at 1 o'clock. Because when you're working with individuals that are at 100% of poverty level, they just can't get off at McDonald's, at Walmart, and get the time off to recover that piece of income that's going to be lost because they went to the clinic. So we had evening clinics, we had dinner for them, so we made different opportunities for that piece of healthcare. And so I'm going to be quiet, Christina, because we know Brenda wants to talk, and I'm going to let Brenda talk.
Thank you, sister girlfriend
Yes,
Carla.
it's my sister girlfriend.
Absolutely. I will say it every time. I survived because of the Harambe Center, as you were saying, welcoming community, welcoming staff, really talking about diversity, equity, and inclusion at the time that we didn't have those terms.
That's right.
When you walked in and at that center that maybe some of you would recognize on South Park Street, we're now behind the Urban League is now. Pretty amazing. So I absolutely agree. I wish I can be on that side and listening to all of you, because that's what I certainly appreciate, the history of what all of us have been doing together. And many of you, I recognize some of your faces over there, that I know that you have been part of that history in the community. I never thought that at one point that I could say that I have a historical perspective, because I came here to go to school, young, fighting for, the rights of immigrant myself, with a lot of privilege and in ways that we have been connecting to this community. Recognizing, I know that at some point we're going to go talk about the tough things that we need to continue to work on, but at the same time, I think it is important to recognize the good things, the welcoming environment that this community has provided for some of us. I want to mention something tangible that talks about interpreter services. 20 years ago, for example, probably you don't even think that now, that we didn't have interpreter services in the healthcare systems, because now every single healthcare system has a team of qualified interpreters that are part of the staff, but also independent interpreters that we hire in the different healthcare systems. Not only that, but because of that push of making sure that we provided services in the language that the patient understood, that also created the next level of understanding how we needed to engage professionals, bilingual, bicultural professionals. And that was something, and that is something that continues to be a push, because we know how difficult it is to find the diversity in some of the professions, not because there's not enough numbers. Let's just forget about that. Let's not say that as an excuse. We really need to create access for some of those professions. So I know that access, I love, now I'm a patient of access. And I like it because I can find a provider that speaks my language, and whenever I feel the sickest, or whenever I need to talk to a professional, that I can do it in the language, again, that feels more comfortable for me. But I'm very proud that all of the healthcare systems got together. We said we need to stop this, just calling someone from the hallway to say, can you help me? The patient speaks another language. Can you help me interpret for that language, for that patient? Or not only that, but also using the children of that family. Not okay, not okay. It created a lot of difficult issues.
Yes.
So the healthcare systems got together and said, let's all fund and really support the training of bilingual staff, professionals that are bilingual, to create that interpreter pathway. So we started creating classes, trainings, for specifically, not only for just bilingual staff, but also creating the next step of really learning translation and interpretation skills. Now, 20 years later, we have a nationally certified process that all of the healthcare interpreters have to go through. So very proud of that. Not only that, but also anyone that may be professional, good heart, that habla un poquito de español, that not also okay maybe in that translation, in that transaction of the healthcare system, but now we have a test that also helps us understand if you are fluent enough to be able to deliver the service in that language. So again, very proud of the fact that we have come together, really work all the healthcare systems to provide the support that we needed. Not only healthcare systems, but also the higher education. Madison College also created a training for translation and interpretation. Thank you.
Thank you, Brenda.
Christina, can I pick?
Oh, go ahead.
Here we go. Can I just piggyback on that and with all this said? We talk about a recent event. Just recently, all the HMOs in Dane County access SSM Health. We talked about this earlier. Your question was about COVID-19 and the disparities and inequities that we see. And so in August, every Tuesday, in a community that is of need in the Leopold area, all those HMOs got together collectively, brought their own marketing things collectively. Access had our interpreters, and we provided COVID-19 and vaccinations right in the community, right outside, right where they are. Provided them with a dinner meal. We had food trucks and ice cream trucks, and if the children were there, that means the parents came. That means we were able to have a conversation about vaccine hesitancy of people that looked like you. So I could talk to a Black person, they could talk to me, and that builds trust. And so you can move that dial for that vaccine. And so I just wanted to mention a live example of how that collaboration worked in Dane County.
Absolutely. And Ken, you have another comment?
You said it at the end of your statement there, Carla. I mean, what we're really all talking about here is trust. And, the pandemic has been, in a lot of ways, another rude awakening for us, that people don't have sufficient trust in the healthcare system to do what we need people to do right now, and that's to get vaccinated. And so that idea of how you build trust is I think, gets back to that idea of how you are more equitable and how you provide access to people. Because you can create programs, you can have access to health care, but if people don't trust the system, they're not going to come in and take advantage of that. And if I could just spend a minute or two talking about, we've been talking about this at the local level, but I think one of the answers to the question is, how do you do this more on a national level? And I'll talk about what I know best, which is community health centers. And so community health centers started during the war on poverty, when things like Medicare and Medicaid were created, the food stamp program, expansion of Social Security. And there were two community health centers that were first started, one in Boston and one in Mississippi, to represent the need for urban health care and rural health care. And so if you then fast forward over the years, there's been significant growth in community health centers, and that has been something that has not been a partisan issue. There's been expansion in just about every administration since the late 1960s. To get to where we are today, which is 1,400 health centers across the country, located in thousands of communities, caring for about 30 million people in our country. And so when you think about the model of care, how do you create a model of care that really creates trust in the community? And Beth talked about that. Is one of the ways you do that is you have a behavioral health system where people don't have to schedule a behavioral health visit. They come in to see their medical provider, and if they have a need that day, the medical provider goes out and gets the behavioral health consultant and brings them into the room to talk to the patient. That's the kind of thing that builds trust. The other thing is recognizing the different needs that people in the communities that we serve have. Dental is an enormous need and an unmet need, even in our community, significantly unmet. And so health centers are required to have dental services for patients. And similarly, how do you care for people that don't have insurance coverage? Because we know that there is some percentage, it's much lower since the Affordable Care Act, but there still is a percentage of people that don't have coverage. Well, at community health centers, you create a sliding fee scale for people based on their household income. So you're providing quality care, but also affordable care for people. And along with that goes pharmacy services. So community health centers also have pharmacy services with steep discounts for people that don't have insurance so they can actually afford their medication. Because we know, if somebody prescribes medication for the patient, they go out to the pharmacy and there's no way they can afford that. How do you build trust with that patient in that particular instance? So, there are lots of ways to think about how we can do this better nationally, but community health centers are certainly part of that answer.
Great. Thank you, Dr. Loving. We've talked about a lot of things, and I think the one thing that, we need to tease out is that people group health with healthcare. And they're two very distinct and different needs. So I'll start with you, Carla. When we think about the work that you're doing in creating social connections in the community and programs, how do you think about connecting to the community so they have optimal health in order to seek healthcare services?
Sure, optimal health. That's big, optimal. Optimal health is an always ongoing piece when you're, especially, I am tunnel vision. I've worked for Medicaid, the most vulnerable in our community for 27 years. So that's my place of reference. I should make sure I say that. But is, again, meeting them where they are. So I'll give an example. So we work with prenatal moms and families. And at times, when you're on Medicaid, again, at 100% of poverty, you're very transient. You could lose your apartment. You could then live in your car. You could then be house serving to this house, and you have a newborn baby. And so what we've done at Quartz, this is one of our programs, is that we have a closet of pack and plays, and these are mobile cribs, if you want to call them that a family can take with them so the baby can be safe. And so we educate them on safe sleep, meaning we would not have them sleep in the bed with them or on someone else's bed, on grandma's bed, but in their own space on a flat surface, alone, no blankets, but it's right next to mom. And so she still feels safe in that area. And so we have diapers and wipes and baby clothes, anything that family, a baby may need at that moment. And we don't stop there at the baby because mom may have a 2-year-old. And so we provide, if she needs diapers for that 2-year-old, we provide that. If they need, where's the food pantry? We provide those resources to them. If they need transportation to their appointments, if they're in our one of our, we call OB medical homes, we provide transportation to the food pantry, to get their pharmacy, wherever the need may be, because we want an optimal birth outcome, a good birth outcome. And so that's one of the programs that we do at Quartz to help our families, our moms, to have a safe delivery. And again, even in that midst of the housing piece, we go with them for that also. We try to find housing. I have been to many eviction hearings where at times the judge will turn it around because we found resources for them. So again, when you talk about health and we talk about behavioral health, it all is this, because I come from family practice as a family practice nurse. It all comes together as this. You can't separate the patient, the family, the issue. You can't separate it. It has to come this way.
I mean, you're hitting on the system, right? Like it's the whole piece, and I think that's really huge. And the other piece, Carla, that I think you highlight is understanding the context, right? There's social context to that
Yes.
piece, and also not shame and blame, right? But
no.
instead, it's a curiosity and an understanding of what's happening, and then here are some resources, right? And how do we help guide and empower to access those resources?
Yes.
I think healthcare at a time can really be very prescriptive, right? We're looking very much for what's the problem, right, to fix. What I think is so important about this collective and collaborative and discussion is really this listening to the individual, right, and the patient in that moment, and highlighting strengths. I'm humbled daily about the resiliency
Yes.
of the patients that we serve and the ways in which they're navigating a lot of adversity and thinking about systemic barriers, right, that are in place and that potentially have not the frame of reference to be able, or scale, right, to move on their own, so that we have to look at then systems to say, how can we have a collective impact to move this forward together? But it's that partnership that I think is so important. And so when we think about a different way we're delivering healthcare to have an optimal outcome, it's honoring patient voice.
Yes.
It's being willing to listen, right, versus being prescriptive and saying, this is what's wrong, here's how we can fix it, because it's not that easy. And I think just coming in with that humility and curiosity as we navigate together. And you hit on the behavioral health piece. You know, when we think about birth outcomes, we have to have awareness around domestic violence, safety at home, housing, postpartum depression, right? Perinatal mood disorders. All of that is so important, and not to come at a place of, here, I'm going to diagnose this is what's wrong, but instead, here is the adversity that you're navigating, and how can we collectively support you and your family as you walk this path?
And know that those lived experiences are their truth.
Yes, yes. And bearing witness to that and validating that. right?
Absolutely.
If I can mention a couple of things.
Please.
That make this information and experience very concrete, that I feel that access and certainly courts make it a priority. One of them is how we partner with community organizations. The Latino Health Council in our area, very specifically having a radio program, and I know we have very famous people around here that I know that are part of that radio program and that commitment. And again, making sure that, as you were saying, Dr. Beth, bringing systemic barriers down, making sure that we support that idea of bringing the voice of the community directly to our systems is so important. So we host a partnership with the Latino Health Council once a month, a radio program that talks about different topics, and making sure that we create awareness, communication to the community in their language that they understand, and also prevention, right? I mean, a lot of times we ask our questions about why this community doesn't do this or why this other community doesn't do that. Translation and interpretation is not the only thing. We need to make sure that we see us represented by providers that speak our language, that connect with our culture, and that creates a very different relationship. So that's one concrete example. The other one is Access Community Health Center has a Latinx patient council, in English patient council, making sure that we bring that voice of the community of our patients directly to our providers, directly to our system. Now, completely different, that has changed our relationship with our patients, with our community, because we're listening. We are really putting all of that feedback into the changes that we need to see in our community center. I'm, again, on the board of Access, and I feel very proud to make sure that I highlight how our systems are changing to make sure that we have diversity, equity, and inclusion in place and as a priority that Dr. Loving, of course, has made, not only for the organization, but also making sure that he talks to all of the leadership to emphasize that conversation.
Yeah, thanks, Brenda. I really like this question because I think we confuse healthcare with health. Mm-hmm. And most people have probably heard about social determinants of health, but those are the conditions in which people are born, grow, live, work, and age that shape health. And so, the actual health care that we provide certainly influences that, but there are lots of other factors that influence it a lot more than that. And so that idea of how do you influence those other aspects of health if you're a healthcare provider. One of the ways that we do this at Access is we know that our community is rich in resources. Yeah. The problem oftentimes for patients is navigating all the opportunities that are available out there. And so we have a staff of community resource specialists so that when patients either come in with questions or they finish the visit with one of the providers, they can go out and talk to the community resource specialist about some of these issues like housing or food or employment or the whole host of things that if aren't going well for people are going to contribute to a negative health outcome potentially. Mm-hmm. So the other thing that we're starting to understand better is that when health systems invest in these other areas, these other social determinants of health, like housing, it actually decreases expenses in some studies for medical care. And so, this is essential for our communities, but it also might be the right business move to be making. And that's something that I think we probably should have been awakened to long ago, but there is more kind of momentum around this currently.
Excellent, thank you. We have been talking about COVID-19 and certainly the impact that it has had on underserved communities. During COVID, we really had to switch from a healthcare delivery model to digital care. And I'm wondering, Dr. Beth, if you could comment from your vantage point, how that's impacted the patients that you see and what we can talk about in terms of digital care and its path towards our future with these communities.
Yeah, so, I think that's an excellent question, and I think how we leverage and define what digital services or virtual care is going to be crucial. From my vantage point, the increase in demand for behavioral health services over the last 18 months is something I've never seen in my career. And the ability to leverage virtual visit to engage people at a time that was familiar, acceptable, without having to take off work, have transportation, find childcare, it removed a fair amount of barriers to accessing services. And the missed appointment was much lower in the context of leveraging a virtual visit. However, I think we need to be very intentional for how we define virtual visits. And the reason I say that is initially it was saying that it should have audio and video capabilities. For our patient population and many individuals in underserved communities, the video component was something that was very difficult to access, either from a broadband internet availability, having the actual AV equipment, or to having the plan, right, to cover the digital services. And then digital literacy, I think, is another real significant barrier when we're rolling out these other systems and click this link and follow this, and are they available available and the directions in a language other than English, so they're easily accessible. And so what we're doing to really how we define virtual care, and really what we've done at Access and worked with Medicaid and the Wisconsin Primary Healthcare Association, is to say telephonic only is a very important tool as well. So we don't unintentionally create greater disparities in accessing virtual services by saying it must have, right, this video component. And the other side of that really had a lot of discussion point was mental health parity. And so in medical services, if telephonic only was going to be approved, right, how do we ensure the same is true for a provision of behavioral health services and behavioral health, including mental health, as well as substance use disorder treatment? We've seen a significant increase in opioid fatalities and substance use in the context of the pandemic. And so timely access to those services, again, if it's a phone call and that visit is going to get someone connected to the recovery support that they need, we want to make sure that that's reimbursed and sustainable, right, provision model of care, but also that the individual can get the care they need in the modality that works for them and the time that works best. And so honoring, again, patient voice around what works well with virtual care and what are some of those barriers to ensure we're not unintentionally broadening the disparities in accessing virtual services.
Dr. Levy?
Yeah, I think this is one of the things that we did really well during the pandemic is make the transition to telehealth, or in some cases video health visits, because at the beginning of the pandemic, for us as healthcare providers, that idea of trying to keep our patients out of the clinic, is exactly the opposite of what we typically try to do. And so it was a great relief to realize that, many times a telehealth visit was sufficient to at least connect with the patient. And I think what we're learning now is there's some encounters that work pretty well that way. There's others that don't work at all, of course. But how do you meet the patients where they are and give them what they need? And a lot of times, one of the biggest barriers for people is just getting to appointments. We talk to parents all the time who have to take, half a day off work to take their child to the dentist. And so we have a program at Access where we've provided dental care in the schools. And that's been a great program that we call Celebrate Smiles. But I think the same is true with, telehealth and video visits, is how do you help patients access what they need more easily? And if you can remove that, hour-long bus ride where somebody has to bring, their kids to the clinic with them, that's a good thing.
If you don't mind, Carla, we get some really great questions. We have a highly engaged audience, so I'm going to try, because I know we're running out of time, to do a rapid fire on some of these questions, since these are what people want to talk about, if that's okay.
Go for it.
So one of them, which is a really pointed question, is we've heard a lot about all the great things that have been done, but what still needs to be done to move us forward?
Yeah. Can I
I'll start with you, Brendan. Yeah.
Just because I think that a lot of times I hear, because of where I have been in my career, working in the healthcare system, hospice care, that we talked about, but we don't have nurses of color, for example, or other professionals. That's maybe very specific situation or case. And I thought, now working for the university, connecting with the School of Nursing, for example, well, what's happening in our healthcare system, in our higher education? What are the barriers that we have there or somewhere in the system that is not allowing us to improve the hiring of professionals of color in our healthcare systems? And that's where you start looking at, let's talk about the stuff, the hard stuff. How is that systemic racism exists? And they're part of our systems, and how do we address them in a way that is not putting off some people, maybe creating the conversation that we know is going to be tough, and then started creating some programs. So, for example, one of them that I know is just, I know that all of it has improved, but it started when we look at the training for CNAs, the nursing assistant level. We said, well, if there's an opportunity to start that career there, a pathway, let's start doing that. And it was really powerful to see Madison College, for example, right away saying, absolutely, let's start changing some of the things internally. What are we not doing well? And then externally, how are we connecting with the community to create some of those programs? Of course, now some of them, one organization I learned that not only is creating support and scholarships for CNA program, but also once that you're a CNA in that particular system, then there is additional support to continue your career for CNA or higher education. So that's a great example, I think.
Real quick, I would say the elephant may be in the room. You mentioned it,
Yeah.
but we've had 400 years of structural oppression and racism in every system, in education and housing. We talked about this in health, from every system. And so when you begin to understand and conceptualize that and intentionally begin to work on dismantling that, then we can maybe begin to move this dial in a forward manner. But we have to recognize it. We have to call it out. And we have, and because the systems were not built for people that look like Brenda and I. They look like the majority. And so trying to dismantle that, understand that, will help in those different arenas. One of this is the program that we're doing during the Health Council is the maternal and child health. We understand that, but it's going to take time to do that. It's going to take time for providers to understand that. I have been in Madison since 1976 when I came to go to school, to college. I have not yet had a black provider that looked like me to take care of me. But what I do is try to intentionally find a provider that understands culture, my blackness. What are some of the things that we should be looking at? And I know that because I ask them maybe some questions. I interview them before they take care of me. So, again, that's a hard question, but that's the question that needs to be answered. So whoever asked it, thank you. Dr. Loving or
Well, I would
Beth?
I should just stop and say I agree with Brenda and Carla and leave it at that, but I will say just a couple of other things.
Good, go.
One is that, that concept, I mean, there's growing evidence that people, if they have a provider that is from their same race or ethnicity, they're more willing to get screening tests done. They're more willing to come in for appointments. And that shouldn't be something we need a bunch of research to show.
Right.
I mean, we know that. The other part of this, it's so important because all the things that we talked about that we've done over the years, what hasn't happened is a change in the disparity data. So we're still not doing what we need to be doing.
Dr. Loving, I'm going to ask another question because it connects nicely. When you think about your patients and the communities, how do factors like shame and negative stigmas influence someone's decision to seek the resources and services that they actually need?
Yeah, no, I mean, that's a great point. I think, I mentioned before, for people without insurance coverage, we have a sliding fee scale for people, but, they have to come in, they have to ask for that, they have to fill out paperwork around that. And we try to do that in as compassionate way as possible. But I just think navigating the healthcare system is complicated for any of us. And so when you think about what that means for our patients, a lot of times, there are just a number of different steps that they need to go through in addition to what we all typically go through when we have insurance coverage. So it is another barrier for people, for sure.
When you think about the topic today, what are your thoughts on elementary schools serving as health clinics for the communities this school serves?
To think about doing that in the health?
That was one of the questions
Right.
from the audience.
Yeah.
I mean, I'm thinking like, I wasn't quite sure if it was like in past, we have done that.
Yes.
Right, and something changed to not have those clinics anymore in the elementary school anymore in the school system, but certainly opening other opportunities at the healthcare system, and healthcare systems partnering directly with the school district to connect with the schools, I think.
Yeah, and there's certainly models for that in other parts of the country, and community health centers are often part of that. We have, I mentioned the dental program that we have, so before the pandemic, we were in 46 elementary and middle schools in Madison and Sun Prairie, and so we were getting restorative dental care. So this wasn't just screening, this was a dentist doing care in those settings. And we're getting that going again now, but I hope that can be a path to doing more of these services in the schools, because I think the reality is that, you know, again, getting to the clinics is difficult for people.
One of the two more questions, I know we're almost out of time, but when you think about your patients, how amenable are your patients to birth control counseling?
Very amenable. I think that's one of the most important things that we're able to provide. And, you know, again, it's developing trust with people so that you can have those conversations with them, and they can tell you, you know, exactly what it is that they're hoping for.
Great, great. Last question, and this is, I'll ask each of you to respond to. From a health literacy standpoint, how are we helping our minorities navigate healthcare from a health literacy standpoint? How do we help our communities understand how health insurance works, what the terminology, how to navigate through it, et cetera?
So, I'll,
Go ahead.
don't want to toot Quartz's horn, but we have in the audience Diego, who is our Quartz manager, who has developed Healthcare 101 in both languages to go out in communities of color, Black and brown communities, to help them understand what healthcare insurance and how to navigate is all about. Honestly, we probably need also the class on how to navigate the healthcare insurance, because it's very interesting to navigate. So we do have that piece, and I just want to throw in real quick regarding another piece. We were talked about it earlier about, you know, going out into the communities and being diverse. On Quartz's outreach team, we have a very diverse team that's able to meet those racial and ethnic opportunities that they face in the community. Because pre-COVID, every conversation now we'll be doing pre-COVID, post-COVID, but pre-COVID, we were, you know, doing home visits, and that was another way to do that. And to answer the quick question about education in the schools, we did do that 20 years ago, bringing healthcare and health checks, and we found, and dentists, all at a voluntary level 20 years ago to do that. But the great thing that you may not know, and you probably do, but Madison, again, is very unique that our school department, MSD, almost has a nurse in every school building. That is very rare in the nation. Dr. Levin, you can kind of correct me if I'm wrong.
That's true.
But that is one that's very unique in our area. So I just wanted to throw it out there.
One point, very similar to what Carla was saying. Thank you for being here, the Quartz team, and connecting with community. The allies are very important, but diversifying the staff also. But one thing that also I think it is important to recognize is how the communities are also very concerned of their own knowledge and information that they need to seek. So the partnering with the community is very important. Having communities organized the ways that we have here in Madison is important to recognize. So it's not only the healthcare system coming to tell us what to do or how to learn about some things, it's also saying, yes, we need to learn, and this is the way that we want to learn. So recognizing that connection, I think it is really important, and that changes the way that then I trust going to Access, going to any of the healthcare systems. And we have done quite a bit, not only changing, as you were saying, the 101 in different languages, but also bringing it to in a way that we can access it very easily through a radio program, for example. That has been amazing, really connecting with a lot of different people in the community, in particular that speak Spanish, but I mean, I know that there's other opportunities for other communities as well.
Yeah, I just think the one thing I would add is what we talked about before, our community resource specialists. So we do this on a sort of individual basis with people based on what they need in the moment. Like if we're making a referral to a cardiologist, we sit them down and talk about what they need to do to make sure that happens.
And I just want to bring Beth into this conversation real quick, because what I see in our schools is our young children are dealing with a lot of mental health issues.
Yes.
At kindergarten, my son works in the school district, so can you, I'm not supposed to ask the
No,
question, but
please.
I wanted to bring that piece
Well,
in
I
of the
think
school.
it's a huge
have
piece.
questions
You
too.
know, if we think about, it's almost been, 3 different school years now in a row, right, where our children have been asked to have a very different, right, routine and learning model and virtual services. And, the school a lot of times is seen as that safety net with those connections, right, and the supports in place. And when we flipped to all virtual, that resource wasn't as accessible, right? And those touches and those access points weren't there as frequently. And so we're seeing a lot more related to anxiety, adjustment difficulties. But we also know the family stress and strain, right, was significantly impacted, whether it was housing insecurity, loss of parental, employment, food insecurity, right? All of those things. And so when you think about kind of the toxic stress, right, and adversity of childhood, those are very impactful. And ensuring that we're asking questions, right, when people do come into our healthcare system around needs and those other social needs outside of, the physical health and mental health piece, I think is so, so important. And, the initial question asked us, what are we doing as healthcare providers to help understand? I think the piece also, when you have the individual in front of you, is taking the time to listen, taking the time to provide education. For me, when we're talking about mental health, a lot of times it's just that important piece around there's not something wrong, right? Like you didn't do something wrong to this child, and that they're not being bad, right, intentionally, and we're not labeling and shaming in that way. But instead, we're saying these behaviors are a manifestation, right, of challenges and adversity, and potentially, we're having sleep difficulties because we don't have a place to sleep at night consistently. And so that we're naming that, and we're not pathologizing, right, a reaction that is a behavioral kind of concern, but it's of something that we can, I think, be curious to then help to navigate through together. And so how do you normalize and validate without shame and reinforcing stigma? But then I also think it's that connection to resources. And so behavioral treatment supports, consistent contacts, closer follow-ups. And then how do you leverage, the phone as a tool if you can't continue, right, to make those follow-ups. We partner a lot with the schools. We have really good relationships with the nurses and social workers in the schools, because again, I think it takes a community. And it's not just one entity that's going to be, pushing change forward, but what we're going to do collaboratively with schools and health entities, healthcare workers, families, and on an individual patient level.
The African proverb is, it takes a village.
Yes. Yes.
Thoughts, Dr. Loving?
I don't think I have anything to add. These were really good
Great.
answers.
Well, thank you all for your perspective on how we can continue to advance this very important work to ensure that healthcare is available for all. Thank you to the audience for coming, joining this conversation with us today, and your very thoughtful questions.
Thank you.
We would like to take another moment to thank our sponsors, whose financial support helps make Cap Times Idea Fest the important event that it is. Special thanks to our presenting sponsor, UBS, the Burrish Group. They have been a major sponsor since the very first IdeaFest. Major sponsors include HealthX Ventures, Exact Sciences, and Quartz. Co-sponsors are Madison Gas and Electric, Godfrey and Kahn Law, the University of Wisconsin-Madison, and EPIC. Our Friends of IdeaFest sponsors are Wisconsin Alumni Research Foundation, Madison Community Foundation, University Research Park, Cargo Coffee, Doc Smokehouse, and Forward Theater Company. Our media partners are the Wisconsin State Journal, Madison.com, WKOW Channel 27, and Hinckley Productions. Again, we thank you for your support and for making IdeaFest 2021 a huge success.